Good afternoon, everyone, and thank you for joining us today for this rules workshop. I am Amelia Boyd. I am the program manager for the commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime next week. The documents which will be discussed here today are available in the handout section of this webinar, as well as on our website, which is wmc.wa.gov. All attendees are muted. Panelists may unmute themselves and share their webcam. Attendees, if you have a question, please use the raise your hand function or use the question section, and we will get to your questions as quickly as possible. Right now, I will begin the roll call of panelists and staff. Let me switch over. So Heather, if you would introduce yourself, please.
Yes, this is Heather Carter. I'm an Assistant Attorney General and Legal Advisor to the Commission.
And Dr. Chung, if you would introduce yourself. He may be trying to log in.
Hi, this is Jimmy Chung. I'm not sure if you can hear me very well.
Yes.
I'm a general surgeon and I'm a member of the Medical Commission.
Thank you. And Mr. Farrell?
Hi, I'm Michael Farrell. I'm on the commission staff. I'm the policy development manager.
And Dr. Small?
Hi, this is Bob Small. I'm a psychiatrist and a member of the commission.
And Dr. Yu? Oh, she's still trying to call in.
Yelling you, public members.
Thank you. And Mr. Malden, if you would introduce yourself and then you can read the script, please.
Yes, John Malden, Chair of the Commission, public member. Good afternoon. My name is John Malden. I will be the presiding officer for this rules workshop. Today is Wednesday, June 30th, 2021, and it is approximately 2 p.m. This meeting is being held via GoToWebinar platform. I should say the GoToWebinar platform. The rule being discussed today is regarding our proposed clinical support program. The pre-proposal rule package is filed in Washington State Register as 1806007 on February 22nd, 2018. We will now discuss the draft language.
So the draft language is in the packet. However, we've gotten a suggestion to change subsection 1, which is on your screen. Hopefully you can see that. Yes. And so there are some options for the second sentence, and those are in brackets.
And can I ask where this suggested language came from?
Mr. Farrell?
Yes. At the end of the workshop last time, we worked hard on this sentence and came up with that first sentence, and I felt it was a little bit awkward. So after the workshop, I went back and looked at the purpose and tried to put in a sentence or two really describing exactly what this is all about in a very clear way. So it came from me. The first sentence, I tried to capture the purpose of the clinical support program. And the second sentence, I tried to address the nagging issue about what is a practice concern or practice deficiency. And so I looked at other states and I came up with 3 different options. So the first option, for example, would be a practice concern is conduct that, if continued, could present a risk of harm to patients, period. Second one would be a practice concern is conduct that, if continued, could result in a violation of the Uniform Disciplinary Act. And the third one could result in the commission of unprofessional conduct. So I'm offering that to you. You can, of course, disregard it entirely, but I thought it might be a more clear way of introducing the rule and stating what it is about.
Okay, are there comments? Yang Ling, you have a comment?
Yeah. Yeah. Can you hear me?
Yes.
Yeah.
Okay. I actually like this revised paragraph. I felt is more clear and more precise on exactly what this clinical program is for. As far as those three choices, phrases, I like the second one. A practice concern is conduct that, if continued, could result in a violation of the Uniform Discipline Act, because under Uniform Discipline Act, it says very clear it poses risk of a patient harm or cause harm. So the risk of a patient harm is already under the UDA. So that would cover the first phrase, that proposed phrase, present a risk of harm to patients.
Dr. Small?
So I would tend to agree with Yangling. I'll just comment, and I've commented on this previously, so I'm being somewhat redundant, but the original purpose behind this was to address issues that the commission feels do not rise to the level of issuing a STID, but nonetheless need to be addressed. And so, so we've chosen the term practice concerns for that. We haven't really had a mechanism for doing that before. So way back when we first had the rules workshops, and Amelia, I don't even remember anymore how long ago that was, but I had actually suggested something along the lines of the second phrase there in terms of violation of the UDA. And I still tend to favor that. Though, Mike, I do have to ask you to remind me, there were some concerns about that when we had our discussions long ago, and I can't remember exactly what the concerns were about that.
Well, the concern was that if we say in the rule that there is no violation of the UDA, then there's no incentive for a physician to participate in the program. So if we say could result if continued to be a violation, then someone may see the value in taking these corrective action steps to avoid discipline now or in the future.
Okay.
Hi, this is Jimmy Chung. I'm sorry, I'm calling from a computer that doesn't have a camera, so I can't raise my hand. But my only, I would agree with both Yanding and Dr. Small. My only question is whether or not is it within our scope to improve the quality of patient care. Quality improvement has both a specific definition and also can be very broad, perhaps beyond the scope of what we do as a medical commission. Because quality improvement is not is much broader than of course in the UDA or WAC and what's defined for the purpose and mission of the medical commission. So I might suggest that we choose something other than improve quality of patient care so that it's a little bit more narrow within the scope.
Dr. Lewis, are you participating? I can only see 4 individuals on my screen. If you are, please speak up.
She is not here, no.
Yangling, you had a comment?
Yeah, same as Dr. Small. From the beginning, my understanding is the same as why we have a clinical support program. That is, we cannot take action but there's some concerns about the practice. So I think the second paragraph, second phrase that proposed is exactly reflect why we have this clinical support program. As far as Dr. Chung's comments about quality improvement, I can understand what you're saying, but I felt like this is still your voice is breaking up from my end, so I may not capture exactly what you said. So if I misunderstood, just correct me. But from what I understand about this clinical support program, if we implement for a particular complaint, as a result of a particular complaint, it would be target focused quality improvement. The action. So it still fall under the big umbrella of a quality improvement, but it's more focused on based on particular concerns from patients and from the commission.
Yeah, I think my concern with that is that not all issues with quality is a violation. Quality, especially when it comes to metrics that are, determined by like CMS and others. It could be things like, hospital-acquired infections and, or things like that. Are you giving certain antibiotics on time before surgeries, things like that. That all goes under quality of care. I don't think the commission is really focused on or has the jurisdiction or I guess power to really oversee quality improvement. And so I just wanted to make sure that we either define that better or just use some other word than quality.
Right.
Dr. Small?
So I appreciate what you're saying, Dr. Chung, and I think you have, given some of the work you do, I think you have a really good perspective on that, and there could be a misinterpretation of what the word quality means, and so kind of getting into the weeds, I wonder if we should just take that out and just say to improve patient care. So the purpose of the clinical support program is to improve patient care.
Yeah, I took a little more simplistic approach as I normally do. So taking the statement that was crossed out, the purpose of clinical support program is to address a practice concern identified in the course of investigation as a risk of safe patient care, period. I don't know that we want, and I agree with Dr. Chung that quality of patient care and all of those issues are not what we're trying to address here. What we're really trying to address is a concern that was identified from a complaint, period, and that we would like to help the physician correct that if the physician chooses to use the clinical support program.
I like the two-sentence structure here that Mr. Farrell has proposed. So, another possible way to do this is for the first sentence, we could just say, the purpose of the clinical support program is to proactively support physicians to quickly address practice concerns, et cetera.
Yeah.
Feeling?
Yeah, I actually, after thinking about all the comments, Dr. Chance and you all, and I think probably we could just keep the original first sentence. So the original first sentence, you said the purpose of a clinical support program is to address a practice concern. Then the next one say a practice concern is a conduct that even continue. So that actually flows very well. First, you say the program is to address practice concern, and then what is a practice concern? Then you explain what is practice concern is a conduct that if continue could result in blah, blah.
Dr. Chung, I think you said you don't have a camera, so I can't tell if you have a comment or not, but if you do, just speak up.
Yeah, I'm a little bit trying to keep up with all the different suggestions. I think it might have been Dr. Small who said just remove the phrase "improve the quality of patient care by," and so you could just say the purpose of the clinical support program is to proactively support physicians to quickly address practice concerns. So just changing the tense of the word supporting would maybe make that flow as you suggested.
That's fine. That's fine too.
Yeah, so we'd have to proactively support.
Yeah, on that one, Amelia, just need to change supporting to support.
Yeah, right, to support.
Yeah. Mike, do you have any comments about that?
I like it the way it is. I mean, the way it's been changed.
And do we want to say quickly address or just address? And what does quickly mean?
Within
comes later.
Within 1 year, is that what's supposed to be?
Faster than usual.
My point is, I don't think we need to say quickly that we will address the practice concern.
And I think the intent there was that we would be able to act more quickly than the process if we have to go through a STID or an SOC. But I understand the dilemma and not having some time parameters around that.
So, may I ask a question?
Yes.
I think I may ask this before. So, it says to address practice concerns through education or practice changes. So if it goes through education, the commission, I assuming we will know what type of CME or class, whatever the action that will be taken. But what about practice changes? How do we know the practice has been changed?
I think if it gets to the point where we had this discussion last time, as I recall, I think we were saying that if it's such a concern that we would want to know that the practice has changed, then we probably should be considering a STID.
I think this gets, I agree with that. I think this gets into that and what follows the clinical support plan. And we're obviously relying on confirmation from the physician or PA, as it were, that they have successfully completed the clinical support plan. But I agree with Dr. Chung. If we feel like we need more than just the clinical support plan and their confirmation that it's been completed, then we probably should be considering a STID. There's going to be some degree of judgment calls in some cases, no matter how we word this as to whether something's appropriate for a clinical support program or a STID. I think it's difficult to have something that's so airtight that there won't be some cases where there might be some discussion about which way to go.
Yeah, it makes sense.
This discussion ties into one of the biggest issues that we have to decide, and that is down in subsection 7. And the issue is, when does the case close? Do you close the complaint upon the respondent's signature and call it good, or do you close it when you receive confirmation that the plan has been completed? So, oh, I'm sorry, it's D.
60. Mm-hmm.
Yes, so 6D, the way it's written now, upon completion of the plan, that's when the original complaint is closed. But you could, we discussed this before, close it upon signature with trust that the respondent will complete the plan.
I would lean towards confirmation from the physician that the plan has been successfully completed.
Yeah, I would support some sort of a confirmation. You either, signature or email communication, whatever that's saying I have completed. It's been documented, and so.
So if there's a practice change, this is going to depend on the facts of each case, but if you suggest a practice change and the respondent signs off on the practice change, if he writes later and says, I've made the change, and submits whatever proof he or she can submit, then the case will be closed.
Yeah.
As opposed to CME, it's a practice change. Let's say the PAs are wearing name tags, or I'm now filing I'm using the electronic prescription system as directed by law.
Yeah, that sounds reasonable.
I would favor that.
Okay, so you're fine with the language in 6D as is?
I'm not. It again uses the language without further action by the commission. Thinking the whole purpose of this is to provide a support plan to a physician, not what kind of action the commission can take against a physician, since this is supposed to be voluntary. I just think it should state that the physician will notify the commission following completion of the clinical support plan. I don't know if we have to say how the individual needs to do that, but again, the focus needs to be on the education of the physician, as I think the support plan should be, rather than suggesting that the commission can do other things like no further action. It just sounds wrong to me, but that's just my thought.
So I think there's a couple things in what you're addressing, John, if I can parse them out for a minute. So, because there's kind of two separate phrases there. So first, when the commission determines that the physician has successfully completed the clinical support plan, I think this is what Yangli and I were saying too, maybe should be when the physician verifies to the commission that they have successfully completed the clinical support plan. And then the second issue is about without further action. So do you have some further comments about that? I think it's without further action regarding the particular case that led to the clinical support plan, rather than just in general. And there is sub C above there that says that that additional investigation or action can be considered if other facts become known.
Right, so and I think my thought is that we should delete C.
Well, my concerns about totally go away with the C is that we basically just say if there's a things something happen, if there's let's say there's a complaint, we say, okay, this is could and put under resolved under clinical support program. Then someone supported some same case relate to same care, but involved, let's put it more seriously, there's a patient death or risk of a harm. You were saying that the commission were not looking at it anymore because we have gone to talk about clinical support program. To me, that really
exactly
laid out.
Right, that's
Go
exactly what
ahead.
I'm saying. It's a voluntary clinical support program. That means we've identified a practice concern, a physician who has been under investigation can voluntarily sign up for this program or not. So I don't know why the commission would care other than the fact that the physician has completed the suggested program.
Well, I don't know. The sentence in C, you could put a if at the beginning of the sentence. So there is a condition. If an additional fact become known, and then commission may conduct additional investigation. But I don't say somehow this would be interfere or in conflicts with the voluntary nature, because it's not like, say, we're holding a stick, we're going to scare you and you do or not. Bottom line is there is concerns about the care issue, and we think it could be resolved very quickly with minor changes of practice or education. And this is all about protecting patients, not go under, deteriorating further into a discipline action. So I don't think C actually is a threatening sentence, but also to make it very clear that this is, voluntary. But if there's something come up, then by statute we have to. I mean, if something same case, and then some patients say, oh no, there's more to it, and here's this, the patient have harmed, then by statute we have to investigate it. Right?
I think it should be a new case. My point is, it's voluntary. It's a practice concern that could be raised by the physician requesting from the commission to participate in an improvement plan, or it could be suggested by the commission. But I think C has a pretty big hammer on it. So we're going to watch you. And if you make any mistakes, or we find out anything else as you complete this plan, we're going to take some additional, potentially take some additional action against you. What incentive does a physician have to enter into an improvement plan if he has the prospect of having some more discipline levied against them? That makes no sense to me.
Yeah.
If I were advising a physician to agree to this plan or not, I would say, don't do it. You potentially are going to subject yourself to some other disciplinary action at the whim of the commission. I don't think we want to do that. I think we want to have a voluntary improvement plan that a physician can request, or there could be a suggestion by the commission that you enroll in the plan.
Well, okay, I understand what you're saying, but if a commission agree or make agreement with the practitioner to into this clinical support program, it doesn't mean commission is still digging. Most of our, digging for dirt, looking at what's underneath it. I think most of our complaints driven by the complaint. So you've made some interesting comments. So you said then if there's a new complaint come up in same nature related to the same provider, by statute, we can open a new case. So I would like to ask Michael, can we, in this case, will we open a new case, or because this is a clinical program involved with the same provider, same case, case is closed, period. It doesn't matter if there is a more serious things surfaced.
You would open up a new case if the original case has already been closed. So I think under this structure, we're keeping this case open until we get verification that the verification that the clinical support plan has been completed under D. The complaint is still open, so there wouldn't be a new case. It'd only be a new case if you close the complaint and then ask the physician to enter into the clinical support program. But that's not the way this has been designed. That's the way it was in a previous version, but that's not this version. I would suggest that we could, since this is causing confusion, may be perceived as threatening, that we just eliminate C. C does not give the commission any more rights than it already has. It doesn't affect the commission's authority at all. So it's merely providing information to the respondent. We can take it out and not affect the rule at all.
Dr. Small?
So I think you raised some interesting points, John. And I think the way C is worded and potentially could be interpreted, as you were pointing out, John, is not the intention of it. But so the question, and maybe I can toss this back to you, Mike, but let's say we eliminate C, and I'm not averse to that. And then we're in the middle of a clinical support program. So we have a physician who's agreed to a clinical support plan, hasn't been verified as completed yet. And, and some complainant brings to light for the commission new information around the same complaint that causes us to think this is more serious than we originally thought. This, warrants further investigation and possibly a STID. What would be the logistics of that, since we still have an open case that's in a clinical support plan at that point? So as you pointed out, we can't open a new case because the case in question is still open and hasn't been closed yet.
Well, I think that I think it would depend on the facts of each case. But if I understand you right, Dr. Small, we've offered on a certain set of facts in a complaint, we have offered a clinical support plan to a physician. The physician has signed it, and then we get additional facts. The commission can take action on those facts. That this rule doesn't quite address that scenario, but the commission can, I would think, withdraw the clinical support plan and take further action. I mean, I guess if we think of an extreme situation where a doctor doesn't have a chaperone and you think they ought to have a chaperone, and in the clinical support plan, he agrees to start having a chaperone, and the patient says, oh, I have a friend who was assaulted by the physician. Well, that changes the case completely. And you wouldn't say, well, we have the clinical support plan, we're good. You'd want to investigate that additional allegation and maybe even suspend the physician's license. You can already do that. Frankly, this is a little bit awkward procedurally, but you're not prevented, and I would invite Heather to comment if she wants to, you're not prevented from taking action based on new information as appropriate.
Yes, that definitely helped me a lot to understand that. But don't you think that should be open, transparent to physicians, so they know that if that's the case, the commission's still going to take action, so they will not say, wait a minute, you got me into this clinical support program. Now there's something come up and you're going to sanction me? So all I'm talking about is transparent, so they know what we would do under certain circumstances. That's what I'm saying.
And I tend to think that kind of scenario would be extremely rare, but I think that that was the purpose of this sub C. And so the question is, should that somehow be called out? Is it, you know, you're saying as an educational matter, or does it come across, you know, too much as a hammer, as John is saying? I mean, we're not going to be conducting additional investigation initiated by the commission while someone's on a clinical support plan unless we get outside information from a complainant that changes the facts of the case. But if we don't have some statement in there, could this mislead physicians into thinking that once they're on a clinical support plan, even if other information does become available, the commission can't take other action because they agreed to a clinical support plan? I mean, very clearly from what you said, Mike, that's not the case, but I'm just raising the question and I don't have a clear answer. Does that need to somehow be called out in an educational manner?
So this is Heather. I agree with Mike that, you know, the commission retains this ability to do this, whether it's in the rule or not. And perhaps the more appropriate place for this sort of notice language would be in the plan itself. I mean, I think the plan with each doctor is going to be tailored to that doctor, but there may be some boilerplate that just says, you know, the commission retains jurisdiction over all complaints that may come in and blah, blah, blah. But it maybe it's not necessary in the rule, and it could be more of an educational piece as part of the agreement.
This is Jimmy. I just wanted to maybe make a comment that I kind of feel like we're creeping into developing something that's like, you know, a low-calorie STID. And I thought the intent of this was really to just provide some guidance and education and not make the physician feel like, you know, they're being punished. Because if we are getting to that point, we should just go ahead and do a STID. So my interpretation of the work that we were doing all along was that we would have all of these cases where we just said, well, there's no violation, we're going to close it. But I really wish there was a way to tell them, you know, you really should, you know, wipe down your counters after each patient or something, you know, simple, so that we can tell them, you know, there's education out there that might benefit you. Not anything where we're going to be like, okay, we're going to ask you to do this and sign and then require you to do something, otherwise, you know, we won't close it. You know, to me, that feels like we're getting to the territory of where something is action and it should be reportable. You know, I guess I'm just having trouble, you know, finding a real clear line between those two scenarios. And I would much prefer that we simplify it to the point where it's more that former, where, you know, we were going to close the case anyway, but we'd like to be able to provide some information and education, and not a situation where, well, we're not going to close until you do this, because if we're going to do that, then that just should be a STID.
No, I agree. Again, we keep mentioning this is a volunteer program offered to the physician, and he or she should be incentivized to increase their education on whatever investigative issue is at stake. If I were a doc with some of the language we have in this document, and I found out that the commission is closing my case after an investigation, I'm done. And if I had to abide by particularly C, I would say, yeah, you're right. I think I do need some more education. Thank you very much. I'm on my own. I'm going to go do this by myself. I don't need the commission's help to get additional education, and subject myself to further commission oversight. I don't see the clinical support program being that way. I think it's an offering to a physician who has been subject to an investigation to improve a particular point of care that could use some remedial learning, but not subject to discipline and not subject to any potential discipline or anything else. And I think if we're going to offer something, we need to make it voluntary. We need to do it without any strings attached, and certainly without any hammer clause in case we find anything out while you're going through this educational process.
I agree with you, John.
So I'm probably usurping your role here, John, but I'm hearing a consensus for removing sub C. Are there any objections to that?
Not for
Well,
me,
I
since I suggested it.
still do not understand why this is a threatening, because to me, big incentive is that this is not disciplinary action. This is not going to be reported to the data bank, and this is a voluntary of what we've said from the beginning. So this is all big incentive, but the biggest incentive should focus on this is how improve patient care. And that should be the biggest incentive to motivate them to do things and to change the practice or take a class, whatever it is. So I still don't see this is a threatening sentence, but if you all voted for to get rid of it, but put it into a educational material, whatever it is, but I think they need to be informed about, not just saying, oh, as long as you in a clinical program, we're done. This is never going to happen. If it's never going to be open, even if there's something new surface. And also because the language as it's written, it didn't say commission gonna dig into it where the still in this agreement for clinical support program. It said if facts become known. And so become known, it doesn't mean there's nowhere I would interpret this as a commission. It's keep an eye on more information, more additional things to try to dig a dirt on it. So I'm just look at it differently. But if that's all you wanted, fine, remove it. I just don't see this as threatening. To me, if I'm a physician, I don't look at this. This is threatening. I say, great. I would do it. Change my practice to be a better physician. That's what I do.
So I think first of all, I want to say, I think, Jimmy a few minutes ago just hit the nail on the head in terms of what the purpose of the clinical support program has been since we first started discussing it, however long ago that was. And I personally did not see this as threatening, but that, we all interpret things through the lens of our own thinking. And I think John made a really good point. We have to keep in mind that other folks may not see things the same way that we do, and it is possible this could be seen by other parties as threatening, which is not what we want in this scenario. So I would be personally comfortable with removing this. I mean, we can always reopen a closed case if additional information comes to mind. And we, as you think about it, we occasionally will have discussions in panel about should we reopen a closed case for one reason or another. There's never anything that prevents us from reopening a closed case if additional facts come to light that weren't available to us when we first looked at the case.
Yeah, I understand what you're saying. So if the decision is to remove it, just remove it.
Yeah, I guess maybe a simple way, again, I don't know if anyone agrees with this, but the simple way to look at it is these are cases that we would have closed anyway.
Yeah.
So we would normally not say these things to people when we're closing cases. It's just, as Mike said, it's automatic. I mean, if we find something else, we're going to open another case. So it's not like, by removing it, it doesn't prevent us from doing what it says.
Yeah, the issue is where the physicians or PA understand that.
Yes,
So I'm making sure they were comfortable with that.
I think you're completely right, Jimmy. I just, again, these are cases we would close anyway, but if we had the authority to issue a letter of education or something similar, that's what we would do. So this is essentially an alternative to that.
Right.
So it sounds like there is consensus to remove or delete C.
Agree. That was good discussion. So I know we kind of jumped from the beginning to this. Is there anything in between here that we had issues with that we need to look at?
Yeah, could we go to paragraph 2?
And you still haven't really decided what you want for paragraph 1 for the second part. So
Right.
you have these 3
I would
options.
support. Yeah, I would support that use of phrase result in violation of a Uniform Disciplinary Act.
I would too.
I'm sorry, I missed, what did you say, Yangling?
I would support this highlighted phrase to select this among the 3. I would support using the highlighted one.
I agree.
It's more precise what exactly this clinical support program is for.
Okay, I mean, I just have a problem with a voluntary clinical support program thinking that we use any language that sounds statutory or has stuff in it that sounds like the commission is going to oversee you all the way through this, and you damn well better do it or you're in trouble. It just doesn't feel right to me to have a voluntary program that has any kind of language in it that is statutory or threatening.
Yeah. Well, the reason I didn't think to use the first one, risk of harm to patient, is already under the UDA. That's automatically. And the result in unprofessional conduct, that is still a UDA. So, and also the sentence said, if continued, could. So it is not something like, say, this is they know the commission is in charge by legislators to make sure that practice under the is meet the standard care. So there's nowhere this would strip the commission's oversight rule.
I guess, I'm looking at this again, I'll use the word a voluntary program. And if we want to encourage physicians to consent to this voluntary clinical support program, we need to make it non-threatening. Otherwise, they're just going to walk away. And I think we recognize the fact that we want physicians to improve a particular part of their care that resulted in the investigation to begin with, that we're now closing because we don't think it was bad enough to warrant discipline. But we raised the issue, and we would certainly like to encourage them to participate in the program and move forward. I'm sorry, Amelia, raise your hand.
So I just wanted to bring up that we've had several requests over the last 7 years working on this rule that we define what a practice concern is. And I think that's what Mr. Farrell's trying to accomplish with this sentence.
Well, I'm brand new to this review, so I don't have the history that you folks have. I just look at it through the eyes of my previous profession. And I think it's great that we would have a clinical support program that we should offer physicians to improve their practice. And I think that's really good. And any language that we use, it should be used to encourage the use and not discourage its use by a physician who has just been, oh, he would probably feel exonerated by an investigation by having it closed.
Yeah.
That's just my point. So, Yingling, you have
Well,
a comment?
yeah, I felt like that, you know, it would the phrase result in violation of a uniform disciplinary action. That is actually it actually help, you know, from my perspective. I'm not a physician, but from my perspective, this would help them to say, I do not want to be sanctioned. This is a voluntary program, and that would help me not get, you know, into, that territory. So that would help motivate them. So I don't take this. I really don't see how this would be a threatening saying UDA, because I mean, commission, they know what the commission is for.
Well, let me just suggest to you that after reading this document, in my former occupation, if a doc asked me if I should volunteer for this, I would say no. Any defense attorney defending the position during the time of the investigation is going to say, no, your case is closed. If you want to have some education, go ahead and do it. But don't volunteer for a commission program with the language as it is stated at this point.
Yeah, so that's a discussion that I think we've bounced around at a number of the former rules workshops. So I think so ignoring the specific wording of that sentence for a minute, one of the other points of this, I'm fond of quoting Alden's perspective on this, even though he's not in the meeting, which is these are scenarios where the physician has not yet gone over the cliff, but if the conduct continues, they are going to go over the cliff. So what we're attempting to do is actually help keep them from going over the cliff. We're trying to help stop them from getting to the territory which becomes a UDA violation. And maybe there's a different way to word this, but I think it's important to call that out one way or another. From my perspective, that's the incentive is you're at risk here. We're going to do this to try and help mitigate that risk. Otherwise, you're liable to go over the cliff.
I mean, you know, for risk manager or malpractice defense attorney, they could say, don't do it. You know, this why you volunteer into a program like this. Fine, because it's voluntary, they will not do it. Then commission has nothing to make them to do it, period, from this documentation. And so if they don't do it, if they correct their own action, take a class on their own, whatever, change their practice, it still change, you know, we still accomplish the goal, even though commission did not, sign agreement with them. But if they refuse just because they think this is threatening, they still keep practicing down the track they were going, then they may get sanctioned. So this is at their own risk. So they either take their own risk or they do something to change the practice to better doctor protect the patient. So that's their choice, certainly.
Again, I'm beating a dead horse here, but I think we need to encourage physicians to take advantage, physicians, MPAs to take advantage of this offering. I think as a risk manager, if I read this and a person just got exonerated by having his or her case closed, you can be certain that a risk management person would say, you know, you really ought to think about taking some CME or a course, but I certainly wouldn't recommend you doing this through the commission. You can do this on your own. This is voluntary, so don't do that. So again, I'll say this one more time and shut up. We need to have language that encourages the use of this program, not discourages the use of the program.
So John, if I can put you on the spot a little bit, what would you do with that second sentence?
Well, I think early on, had a suggestion of very simplified language using the existing sentence that's been crossed out during the course of an investigation as a risk of safe patient care, period. That's the issue. We've identified an issue that's a risk of safe patient care for which we are offering a clinical support program detailed below.
Okay, so John, let me ask you this question. Do you draw a line of which one you consider unsafe care would be under clinical support program? Because all those cases that from patients complain that came to us, they all present unsafe care, but they're big unsafe care, more serious, they are less serious. So are you saying all unsafe care can be put under clinical support program?
Any situation that is unsafe patient care should be eligible for the clinical support program.
But that's not the intention of the clinical support program, isn't it?
But the way I read this is it's an opportunity for a physician to take advantage of a clinical support plan to help the individual improve medical care in a certain set of circumstances. And maybe even more broad than that, if they so choose.
What if there's an unsafe program, but practice that requires commission to monitor the practice for 2-3 years? Are you still saying clinical support program voluntarily would do it?
I think if we want to have a program that requires commission oversight throughout, then now we're bordering on a STID. If we want to go STID light, then we ought to go STID light and make it a requirement. But if you want to make it voluntary, it's voluntary. And again, we just ought to have language that encourages its use, not discourages its use. And I'm beating a dead horse here, I know, but I have to tell you that as this document is written today, there is not one defense attorney who is going to say to their client, this is a great idea for you, sign up. There is not one risk management individual reviewing this issue with the physician who's going to say, what a great idea, sign up. It ain't gonna happen. But if we want to improve physicians' care, we want to improve patient care, patient safety care, specific issues, we need to have a program in place that is friendly and offering something as an improvement without a hammer. Otherwise, no one is going to use it.
Well, that would remove any statutory obligation of the commission. Then we don't need a commission. All we need to do to implement a clinical support program. If there's a complaint saying this is unsafe care, we say go take a class voluntarily. Would that work? If we do a STID, that typically right now is the right level of the UDA. Is that right?
Yeah, I mean, I think if we have enough concerns about the clinical care under investigation, then it probably ought to be a STID. Then it's forced education. But as I understand this, and I know we have lots and lots of cases where it doesn't quite feel right closing it because it's just that the care didn't quite feel right, but it wasn't bad enough for a STID, but it's still a concern. That's what I thought this program was for. And if we want to get it used, then we need to advertise it as such. Mike, you had a comment?
Yeah, I wanted to clarify something, John. I think the word voluntary means different things to different people. When we started this process, the original draft, or we had a discussion for the first couple of workshops about whether the case would be closed and then the program would be offered, or the case would remain open, and then if it's signed, the original complaint would be closed. It sounds like you're suggesting, or you're under the belief that the case is going to be closed, the complaint against the respondent will be closed, and then he will be offered the clinical support program as a way to help him improve his practice. Is that your understanding?
That's my understanding.
Okay, that's not the way this is designed. So I think that we have a misunderstanding there. We discussed this, and that was the opinion of several of the panelists. But the concern was that if you close the case, and you can do this, if you close the case, send the respondent a closure letter, and then send them a document on our letterhead, medical commission letterhead, saying, please enter into this program, which is going to be a public record, then nobody will sign it. Just as you said, no one's going to sign a document saying that I might have done something wrong, and it's a public record that anybody can grab and use against them. So we shifted to a procedure where the complaint would remain open until he signs it or completes it, and that's the way this is written. It's the original complaint is closed after we receive verification that the plan has been completed. So I wanted you to make.
So then the clinical support program is mandatory.
Well, there's strong incentive. I'll put it this way: there's strong incentive to sign it to avoid further action and to improve your practice. There's incentive because that complaint is not going to close until that document, or may not close until that document is signed. It sounds like what you're looking for is more of a letter of concern. The case is closed, but we have a concern about this, and we recommend that you change your practice or take a course in record keeping or do something. And then it's voluntary on the part of the physician, whether he or she wants to do that.
So again, this is mandatory.
It's the respondent, when they're offered a STID, it's voluntary. They don't have to sign it, but there's big incentive to sign that document, just like an agreed order. So they don't have to, but there's incentive to do it to make the case go away. That's what we mean by voluntary.
So the incentive is, if you do this, we won't issue a STID.
Correct. That's the way it's written now.
So it's mandatory.
Okay.
Okay, so that's been my misunderstanding, and I apologize for all of my comments then. I thought this was something that's being suggested by the commission that you do this, not that it's mandatory that you do this or you're going to get a STID. I didn't realize that.
Well, I
Well,
have to interject. I don't think that's quite the case. Again, over the time we've had the different rules workshops, there's been variation in the philosophies around exactly what this is. So there are different points of view, but these are, at least as I look at, these are not scenarios where if you don't do this, you're going to get a STID. if something was STID worthy, we would have issued a STID and not even offered the clinical support program. Again, how I look at this is these are scenarios where we think you're at significant risk of getting into STID territory. And doing this, we think will probably keep you out of that territory. That's how I'm looking at it. I think it is voluntary the way that you envision it, John, but I think that there is a little bit of a stick behind it in that, you know, whether we say this or not, we think you're at risk of a STID if you don't do this.
My understanding is exactly the same as Dr. Small. I didn't feel this program, at least from my understanding, is that if you don't sign this, we're not going to give you a STID, because under number 3, the sentence said, the paragraph said, the commission may resolve a alleged practice concern. So that is the way how you if someone file a complaint by patient or whistleblower, and the commission does feel there's some concerns, and if continue, it could be, like Dr. Small said, fall off a cliff, then we want to have an early intervention at a personal level, voluntarily, to take a class or to change a practice. And so I don't think that there is some threatening things in there that otherwise we're going to give you a C, we're going to section you, because that is not the sentence, if I read, were result in violation of UDA, because it said rule of the practice is pattern is continued as the current one. It could be risky. It said it could. It didn't say you will get a STID.
Okay, again, I get it. I read it totally wrong, and I apologize for that. I understand that you will do this. So I get it.
I think, you know, your points though, John, you know, are really valid in terms of how to motivate physicians to engage in these plans. And, you know, we did, as Mike and Amelia will well remember, we had a lot of discussion about that early on. I mean, in the end, you know, there's no great way to force physicians into agreeing to these plans. But again, I think from my perspective, the motivation is we are trying to help them stay out of continued behavior that, if it continues, is going to likely result in them getting into STID territory.
And I think that's fantastic. And I think we ought to provide that, that educational opportunity. What I didn't understand was the formality of it. So I get it now.
So John, now are you agree with the second phrase now?
I'm sorry.
That's the purpose. Are you agree with the second phrase? If continued,
I agree
the
with
practice
everything now that I
concern for the
know.
concept.
Now that I know that it's not optional, I agree with everything.
Okay.
So we do have a couple of hands raised if you'd like to take those comments now, or if you would like to wait until you're done discussing. But I think the hands are raised because they would like to weigh in on what you're talking about.
Yeah, maybe, well, let me just ask first, are there other parts of the proposed document subject to some question?
I just wanted to comment again, not to beat a dead horse, so to speak, John, but it is still optional in the end. So I still am concerned there may be a misunderstanding about that. We have, you know, we have no way to make this mandatory. And you know, the physician's going to have to make a decision that she or he agrees that they're, on the edge of the cliff and, would welcome some help in terms of a clinical support plan. But if they reject it and say, no, I'm not doing that, and we don't have any additional information that the issues in question rise to the level of STID, then the case is just closed and that's it.
Well, you're confusing me, Bob. But let's take some comments, Amelia, so hear what others have to think.
Okay, Dr. Rochford, I have unmuted you if you would like to speak.
Oh, great. Can you hear me okay?
Yes.
Okay, great. One of my little pet peeves, and I unfortunately had to deal with the medical commission personally and professionally, is this issue of risk. Okay, I really think that all of medicine involves a risk. We're always doing risky stuff. It's a risk-benefit analysis. And given our background, our experience, our expertise, all kinds of factors, we weigh in each of us individually with the risks and benefits, but we can't eliminate risk. So, when I read on my STID because of potential minimal risk, I go, well, I can't practice medicine. There's always risk. I'm always weighing the risks and benefits of all I do, the time I do and spend. So I'm just bringing that up. The other concern I wanted to bring up to the group is that to careful that what this might have in terms of implications, in terms of malpractice coverage, being reported, all the rest. Because, it's almost like you're punished if you don't even do anything. You know what I'm trying to say. As a physician, I want to be on top of things. I'm first and foremost patient interest and well-being. But to try to manage what others consider risk, which I might consider, well, yeah, there's always risk, but reasonable risk. So that the way you've used it here in this document again about risk, I just put it forward as kind of like, wait a sec, everything we do is risky. There's all, I always say to a patient, there's a risk with you coming and driving to see me that I have to take into consideration. That's maybe exaggerating to make my point, but I'd like to, make that point to the commission. We have to be aware of that in terms of helping. Let's assume that the doctor physician has the best intent of caring for their patients and their well-being, and how do we help them do that better? But I do want to just argue this notion of risk and trying to eliminate it just seems untenable. It's just practice of medicine. It's a risky business.
Thank you for that comment. Amelia, do we have another?
Yes. Jeb, I have unmuted you if you'd like to go ahead.
Thanks, Amelia. Good afternoon, everyone. Can you hear me?
Yes.
Awesome. Thank you. So just first, I want to thank you again for incorporating our feedback on previous drafts and for holding additional workshops on the rule to sort of talk through some of these concepts and really appreciate many of the comments that have been made today. Just being really level with you guys, it's really hard to imagine a scenario where we'd recommend a physician participate in this type of program. Just listening to this conversation, it's more confusing to me than ever if this is truly voluntary in nature or if a physician is just left with a decision to make between being disciplined and not being disciplined if they don't do it. So we've been open-minded on this concept for several years, but we feel like we need more information around how the medical commission intends to apply this program. And I know there are some documents that were posted in the webinar handouts that do get to some of what I'm going to talk about, but I haven't had a chance to read them yet. So hoping we can have a discussion still on this call. So we have a list of 8 questions that we could talk through, or we could submit in writing after this meeting. But there's one thing that would be super helpful, I think, to the medical association and sort of navigating what you guys are trying to build. So we would appreciate it if the medical commission could articulate a need for this program, sort of who or what is driving this work, and provide a recent example of a practice concern where this would have been beneficial to physicians, or at a very minimum, like a hypothetical from intake to when you exit the door of this program. What does it look like? What does it feel like? What is the physician subjected to? The rule language is very vague, and so we're having trouble understanding the vision, right? And so, just upon a cursory review of the examples provided in the documents today, in the case of not e-prescribing, which might happen for many reasons, and I think is typically regulated by the Pharmacy Commission, or not completing CME, or not wearing a name tag, couldn't you send a letter to address those types of issues, as opposed to subjecting a physician or a PA to a sort of a more resource heavy a program? These, at least the examples that are provided in the documents, they're not really clinical issues anyway. Many of them are administrative. So it just begs the question: is there a less intensive way to go about getting your concern in front of the physician? And just, again, frankly, physicians and PAs are overwhelmed. Burnout is a real issue in the profession, and they're not going to volunteer to do this without some clear incentive that's not just a hammer. So maybe a letter saying that we've identified this issue, here are some resources to help improve, might be received more positively by the physician and the PA, and they might be more receptive to working on that. Without that type of context and just looking on the words on the page, it looks and feels like a stealth a disciplinary process, and sort of it leaves the door open to pursue discipline. And per the draft comments or the draft documents provided in this meeting, you could be disciplined for not completing the program. So what does that look like as well? So we just have a lot of open questions on what this looks and feels like, and what the intent is. There's been concerns raised about using the program to document practice deficiencies, and then using that as evidence to open up a borderline case at some point in the future. Those are the types of questions that we get about this program, and so we just feel like we need more information. And at the last meeting on this rulemaking, and at this current workshop, there doesn't seem to be a lot of consensus around what the medical commission wants to do with this program. So I have a list of more granular questions, and I don't know if it would be helpful to ask them on this call, or if I should follow up in writing. So we'll defer to you now.
So Mike, can you or Heather speak to Jeb's question about just sending a letter and why we can or cannot do that?
Sure. Jeb, it sounds like what you describe is what we would call a letter of concern, which many state boards have the statutory authority to issue. We do not. We tried it many years ago, and the AG's office said that's not authorized by statute. And if you suggest in a closure letter that there's some concern, then that's a public document allegedly having a finding without any due process, and would subject all of us to civil liability, anybody who participate in it because it's not authorized by statute. So if that's the goal, and that might have been what Mr. Malden was suggesting and other people have suggested, if that's the goal, then I don't think the rulemaking process is the way to achieve that. I think that's a matter for the legislature.
Right. Okay. That's helpful. Have you guys spoken with any leadership at the various health systems. It seems like this would be putting the commission in more of a quality improvement role and less of a disciplinary role. And there are very robust quality improvement mechanisms in these health systems where most of our physicians are employed, and just wondering if you've gotten their input on how they would feel about sort of multiple QI programs being applied to their physicians and PAs.
Not formally. I'll say that the one of the reasons for this is the long-standing frustration of the commission and having very blunt tools given to it by the legislature. We have charges and we have a STID, and because they're both reportable, they are significant. They're both disciplinary and they're reportable. So many states have a tool under various names for minor cases like this one, which we're trying to emulate. And the difference between this tool and a STID or an agreed order is that it's not reportable. So the commission can do something that doesn't go to the data bank, although it creates a public document.
Mm-hmm. Do you have a list of those states where we can do some outreach and sort of learn what the experience is there?
I do.
That would be great if you could share that.
Sure. I can tell you, Minnesota and Texas are two of the ones that come to mind immediately. There are a number of others. Texas has what they call a remedial plan, and Minnesota, I think it's a corrective action plan. Both of those look remarkably like our STIDs. In fact, they go further. They have findings of fact and conclusions of law, but they end up saying it's not discipline and it's not reportable. But both are authorized by statute. And I can send you examples.
Gotcha. Can you help me understand why the medical commission wouldn't have the authority to send a letter, but it does have the authority to create a program like this?
Well, the letter is not authorized by either statute or rule. We believe that a letter of concern should have statutory authority. And Heather, if you want to weigh in, I'd welcome that. I think three boards within the Department of Health, the Chiropractic Commission, the Nursing Commission, and maybe a third, already have a rule like this. And our rule is patterned after those rules, particularly the Chiropractic Commission. They passed those rules, they use this tool, they say it works well, and we watched that and thought maybe this is a way to address the commission's desire to improve care by having something lesser than a STID. So it's already in place.
Jeb, I would suggest that you send your questions in, and if we have time toward the end of our time period, maybe you can ask those questions, but I want to make sure we're going to acknowledge others who may have questions or comments to make at this point.
Great.
We do have one other hand raised. Chelsea, if you'd like to go ahead.
Thanks so much. This is Chelsea Hager. I'm the contract lobbyist for the Washington Academy of Physician Assistants. I appreciate the opportunity to weigh in today, and actually had some similar questions that Jeb just raised. So Mr. Farrell, I appreciate the responses there. This is actually a relatively new issue for me to be working on behalf of WAPA. It wasn't something that was on our radar previously, and new to representing them. And so, I've been trying to understand the history here and what the goal of the program would be. So I appreciated seeing some of the examples of instances where a clinical support plan would be appropriate. The one that jumped out at me of this specific example pertaining to a PA that's not wearing a name badge, I had a similar reaction to Jeb in that I thought that could be something that could be, in terms of resources with the commission, potentially easier solved with some type of letter. So I understand that it sounds like there might not be the authority to do that, but I wonder if there's something short of going through an entire program that can be done to educate either a physician or a physician assistant who might have, made an error inadvertently and if reminded, could potentially not make that same mistake in the future. So appreciate the process here. We'll continue to look over the materials that were available as of today and might weigh in with additional comments.
Thank you. Is that the last comment, Amelia?
That is the last hand raised, yes.
Well, then Jeb, why don't you go ahead and ask your questions? We have more time.
Great. Great. Thank you, Mr. Malden. So just a few questions around, I believe this is section 4. Who determines if a deficiency can be corrected through education or practice changes? Are there criteria that you plan on applying to this, or is this simply going to be in the opinion of whoever is assigned to this complaint? And then similarly, how do you determine it's unlikely to reoccur? Are there criteria there? Who determines when the program has been completed? And if there's a disagreement between the physician PA and the medical commission around whether or not it has been completed, or do you simply take the word, like the attestation of the physician? Those are the first 3.
But if I can weigh in, the answer to the first question is the panel, just like any case. Any completed investigation is assigned to an RCM, as you probably know, and then they take it to the meeting and discuss the case, and that's when the commission decides whether to close the case, offer a STID, issue a statement of charges, and maybe if this passes, determine it's appropriate for a clinical support plan. The other 2 questions I don't have answers for. We haven't worked that out.
Okay. Thank you. That's helpful in regard to the first one. That makes sense. Wondering, are there any costs involved to the actual physician or PA, sort of like out-of-pocket costs? Are you going to require them to take certain CMEs, or is there any other costs associated with this? And then more sort of macro level, how does the medical commission see this in terms of utilization of resources? Is this budgeted program? Is this something that you're going to create entire new committee or a new panel? Is it going to stay within the existing resources of the commission?
As you see in the rule, there's no provision for imposition of costs or a fine. However, the commission could order the physician could agree to take a class in record keeping or something like that, and of course that cost would be borne by the physician. And to your other question, we don't anticipate any additional resources involved in this. We anticipate that this would be used in rare cases and would be rather simple to administer and implement.
Okay. Just a couple more big picture questions. These are my last 2. I've been struggling to understand. So one of the concerns we've brought forward in the past is around this being subject to public disclosure and how the commission can't carve that out. That's the legislature's job. And I don't think there's any appetite to take that to the legislature to ask them to do that. And so just wondering, is the disciplinary process itself subject to public disclosure? And can you help me understand what that looks like?
Heather, are you still on?
Yes, I'm here. So this is Heather Carter. So discipline is subject to public disclosure. There are some patient records that are withheld, different privacy things may be withheld or redacted, depending on what kind of case it is and what's in the file. Let's see, the STIDs aren't subject to disclosure until the STID has been accepted or rejected. So there is that that provision in the law, but once it has been accepted or rejected, then it is available pursuant to a public records request. So this would be similar if someone wanted this document or the file. It would just be subject to review and redactions or withholdings based on, and it's usually privacy concerns and patient records in our type of files.
Got it. Okay, that's really helpful and helping me understand the interplay between the disciplinary process and public records, and including this program as well. One last question is, it's my understanding, could you confirm for me that this information would be available in the credentialing database? Just thinking about any sort of future adverse employment opportunities that might be impacted by having something like this, or not wearing a name tag or something, come back to harm the physician in the future.
You want me to handle that? Okay.
Shouldn't be.
They're public documents, Jeb. They're not going to be on the physician profile. They're not going to be in provider credential search, but it's going to be no secret that these exist, and any credential or anybody, any member of the public can ask if there's a clinical support plan with Dr. So-and-so, or ask for his whole file. Depending on how it's worded, we would turn that over.
Okay. So those are the remainder of my questions, and I think it's safe to sort of express our concern with this at this point, as drafted.
So we do have one more hand raised. Thank you, Jeb. Chelsea, if you'd like to go ahead.
Thanks. Thanks again. One other question I had, Mr. Farrell had mentioned that there were 2 or potentially 3 other boards or commissions that have similar programs in place. And I think it was specifically the Nursing Commission that you said where this is working well. I'm curious if we know whether or not, assuming their program is also voluntary, if there are instances where nurses determine that they don't want to engage in the program, and if so, what has happened in those situations?
I'm sorry, I couldn't tell you.
Okay.
I can find out. That's a good question.
This is Heather too, and I will say that the Chiropractic Commission is probably the one that's more similar to the Medical Commission than nursing. The Nursing Commission program is slightly different because it deals with employers and supervisors as well. So there's a contract between the employer, supervisor, and the nurse and the commission. So it's slightly different, or actually that's quite different than this program. So I think I would look more to the Chiropractic Commission as an example.
Are there other comments or questions?
Well, Jeb has his hand raised again, so I'm going to unmute him, but I'm not sure if he meant to do that.
I did, yeah, I'm back. Thanks, Amelia.
Okay.
I was just looking at the chiropractor one, and one area where it is a little different is they are prescriptive in what types of deficiencies would trigger the program. So they have documentation of care, radiographic standards, billing and coding, advertising or marketing, continuing education, and then they do leave the door cracked open, other minus practice concerns as determined by the commission, but it would give folks sort of a flavor of what this is intended to do.
And we did have that list in our rule previously, but it was removed, I think, 2 or 3 workshops ago. But I don't recall why it was removed.
Other comments or questions? Noted.
That is all we have. Oh, one more hand raised. Go ahead, Dr. Rochford.
Well, this is Kim Baracher. The other thing is this notion in all our affairs of due process with colleagues and who's coming in. If we're going to impose consequences, or when there are consequences, whether it's financial or social or jobs, this notion of what I call due process. And, you know, to be aware of that, if there, is there adequate due process? And sometimes, you know, that's not even affordable or available. The cost or the potential issues around that. So I just suggest that as you guys are looking at this, how does this fit into the bigger picture of due process that, of course, we want for everyone, our colleagues and everyone, when they're being held accountable or not with regard to their behavior. It's just a comment. Okay, hopefully it's helpful.
Thank you. Then we have one more hand raised. Katarina, if you'd like to go ahead.
Hi, yeah, I'm also at WISMA with Jeb. I just had one quick question. My understanding was very similar to Dr. Malden's, and then I think that was sort of rebutted by Mike Farrell. So I was hoping, Mike, you could explain why it is that you thought that Dr. Malden had misinterpreted, because that was our interpretation as well. Just with respect to whether this is actually voluntary and how it would be used and when.
Yeah, I think the word voluntary is problematic. To me, one of the big issues is, as I said before, when does the case close? So if the case, there's 3 different points where the case can close. The case can close immediately upon the commission's review of the investigation, and then they can offer the clinical support plan. And that was that was in a previous version of the rule and supported by a number of commissioners. And that's, I believe, was Mr. Malden's interpretation. Then we changed because we thought that no one would sign such a document. And then we had a debate whether the case should close upon signature with a trust that the doctor would follow through with the clinical support plan. And we wound up, at least at the last workshop, and the draft you have in front of you, the case will close after the commission receives confirmation that the clinical support plan has been concluded. So I'm not going to talk about voluntary and having incentives, but I think to me, that's the way to think about this. When is the case going to be closed, and what does the physician have to do to get that case closed?
Okay, so I guess my confusion sort of centers around in the criteria that there isn't already disciplinary action happening. Let me pull it up, because if you can scroll down.
Okay, I can explain that.
Okay.
That issue is addressed in the procedure, and I guess it's also in the rule. But oh yeah, there it is. When can the commission offer a clinical support plan to a doctor? And the decision was made that they have to offer it right up front. And if they've offered a STID, for example, to a doctor, the doctor and his attorney can't come back and say, we won't sign a STID, but we'll sign a clinical support plan, because it's not reportable. Under the rule, it's too late for that. Once the commission decides to offer a stipulation to informal disposition, or makes the decision to issue a statement of charges, there's no chance for a clinical support plan. That was to draw a boundary around this so that it couldn't keep coming up during negotiations. It's offered right up front as a quick way to settle the case. And then if it's rejected, or if another course of action is taken, you can't go back to that. That was the intent.
Okay. Okay. I think that makes sense. So if say perhaps like this is the plan is considered just based on a public member of the public's complaint, I guess. how, I guess that would be different. Okay, I think I understand it.
Yeah, we drafted it so the investigation would be completed and come to the commission before they make the decision. So they have a full investigation in front of them.
So if I'm being investigated for one thing, and then say within the course of that investigation, you identify some practice concern, you could then offer participation in this program. But if then I don't voluntarily say, yes, I'll participate, is there a situation in which you could turn around and say, well, then we'll discipline you? Because then my understanding is if that practice deficiency or complaint or whatever doesn't meet that threshold, then you don't have the evidence to support that.
Well, each case is going to be a little bit different, but the procedure would be the commission would meet and discuss the case and decide that a clinical support plan is appropriate. It would be drafted up by staff and sent to the physician. And if the physician says, I don't think this is appropriate, I reject it, then it would come back to the commission at the next meeting to again discuss the case and decide whether to close the case or to take further action. That's just going to depend on what's in the file and the judgment of the commission.
Okay. Thank you.
More hands, Amelia?
No, that's it.
Any further comment from the commissioners present? Yangling?
Oh,
One is the first paragraph. We have to decide which one phrase we use. I gather that, yeah, that's highlighted. That's as well. We seem to have consensus on that. Then Michael just had responded to the last person's the question, and I don't know now if this is really presented, this program presented as a choices between STID or a clinical support program, then that will not be voluntary. Because if the person say, I disagree, I don't want to get into the clinical program, then you say, then I'm going to give you a STID, then that is not voluntarily. To me, the voluntarily is say, we have been having situations say, gosh, we couldn't take us, it doesn't rise the level of specified in UDA, so we have to close the case. But we do have concerns. We just felt there was some issue that need to be addressed. Can we have some tool to do that? So this is what I understand what this tool would be. Say, we would close the case, otherwise, no STID, because the STID would get into a violation of the UDA, because we have STID have a 1 year, 2 years, 3 years, 4 years, 5 years, and maybe have a practice monitoring. But with this program, it's not understood. It just say you voluntarily to take a class or change practice. There will be no monitoring. So you can't go back and just say, you don't take this, we're going to monitoring you, because it doesn't rise the level for you to do a STID. Am I right? I am getting so confused now because I feel like a voluntary, that doesn't fit the definition volunteer.
I would love to take the word voluntary out of the document. I'll just say that the respondent at each stage of the settlement process has a choice to enter into the clinical support plan, to sign a stipulation, informal disposition, to sign an agreed order. There's always a choice involved. There's going to be different pressures at each time. But as you know, there's not a clear demarcation sometimes when you're looking at a case. It's not always a case of lack of evidence. You can have firm evidence of unprofessional conduct, but it's fairly minor, and you have discussions. Is this worthy of discipline? You have that discussion all the time, and you have disagreements. Is this worthy of a stipulation in formal disposition that is reported to the databanks. And there's all kinds of factors you take into consideration. So this is designed for that gray area where you're not sure whether STID is appropriate, but maybe you can achieve what you want to achieve with a very simple practice change or taking a course and not having something reported to the data bank. It's not always going to be, we definitely don't have a case, but we wanted to do something.
Right. But the goal is, I assuming the goal is not report to the data bank, is not. The goal is to practice, improve the practice. So whatever is the best way to improve the practice without having to have, negative impact on the physician, right? I guess that is what it is. So if you say, if it's just a minor reminder that you take a class of whatever it is and recommendation, then we'd recommend you do it. But if a physician say, I'm not going to do it, then you can't, I guess I'm still, then the reason we want this because we can't sanction that you didn't rise the level. So you can't say if you don't sign it and if you don't do this, and then we're going to sanction you. You can't. Even you use a STID. I mean, that's just the whole my confusion is. I guess if you take it out non-voluntarily program, and that changes the nature of that, then.
Yeah, I guess I want to add, this is Jimmy again, I guess I want to add, going back to what John was saying, I have to admit that was kind of my impression, was that these were cases that we would have closed anyway because it doesn't rise to the violation. And but we want to be able to send some kind of message, kind of akin to what some of the other folks who are asking the questions were saying. And so I did have a problem with the closing statement, the statement about the closing, that if we're not going to close until we can determine that the plan was completed, to me, that's just like a STID. And so, again, going back to what I had said earlier, I think we need to broaden that gap between what we're talking about versus a STID, because while on paper this sounds like a good idea, like maybe even a STID light that doesn't get reported, if it's a choice between this and a STID, I don't really see this being used a lot at the panel. I think we would just do a STID. What we're really needing is that letter that you previously mentioned that says, hey, we're not going to discipline you, but we've got some concerns that might lead to a STID in the future or something to that effect, saying, we want to be able to say something. And I think that has been the big gap that we've been talking about, is that we have been always told at the panels that we can't say that. We can only say whether or not you're being disciplined, or whether or not the case is closed. We can't say anything else. So to me, that's what I thought we were going to be doing. And again, just like John, that was an idea that was thrown out earlier, then I apologize as well. But as written, to me, this basically becomes a light STID, which perhaps doesn't get reported, but it's still, to me, it's discipline. If we're going to have to hold them accountable until something gets done before we close it, to me, that's discipline.
Yeah, and we talk about inability to write a letter, but when we do an A3 closure, we have language that gives lots of hints to the physician, and it's almost like, it's not almost like anything. it is a closure with hints of concern, I guess. So, but nothing's attached to raising those hints of concern. Still gets closed. Are there other comments?
No.
Okay. Well, at this point, Amelia, we'll talk about timeline, how many more years we got to go, and next steps.
So the next step will likely be another workshop because there's still a lot, I think, some work to be done on this language. I hope to have that scheduled for sometime in August because July, we do have a meeting, but it's next week. And so I think I will shoot for August for this one. I would encourage all of the interested parties on the line to possibly send me their questions, comments, maybe some suggested language if you have that. That way we can look at that at the next workshop. It will be probably 2 hours like this one. As for timeline, I can't even guess with this one. So we've brought it forward for the next step in the process once before, and that was actually approved. And then we rescinded it based on some comments we received. And so I really couldn't speak to the timeline. So Jeb's asking in the chat, when is the next workshop? I think it will be in August. I don't have it scheduled yet. I have to send out a doodle poll and figure out when everybody's available. So hopefully in August.
Yangling had her hand up first, Bob.
I just saw that, for the item C, we could have just take out the commission will close the matter without further action. We just say it would be nice still for the physician to verify they completed if they into this program, and then say when physician verifies with the commission, the commission would determine that has successfully completed the clinical support program, and that close the loop, the communications. That would same accomplish the same goal. That's what we just want to know, that it had been done. Just a suggestion.
I have a feeling the way this is going, we will know when it's done. Because if it's not, there are consequences. Dr. Small?
Yeah, so just an observational comment, having been at most or maybe all of the workshops for this over the last, again, can I remember how many years at this point? But as we've had changeover in commissioners, the philosophies around what this should be have changed, and I think we still, as a commission, don't have a consensus on what this should really be and how it should really look, and I think that's hanging us up at this point. Again, I've said this before, but the genesis of this was precisely because the legislature has not given us and refuses to give us authority to issue a letter of education or a letter of concern or whatever kind of terminology you would choose to use. And we are bound by what the legislature authorizes us to do, so that there is that restriction. But we have been searching for some mechanism to provide physicians and PAs with education about concerns we have that we have decided don't rise to the level of a STID, but still need to be addressed to prevent them from rising to the level of a STID. And I know I'm being redundant, but I just want to again share those overriding comments.
Thank you. I may have inadvertently prolonged the discussion today by not having been
Not at all.
not been associated previously. The newbies don't get the history. Last call for any comments, question. Amelia, anybody with their hands raised? Nothing in the chat?
Nope, we're good.
Okay, well, thank you, everybody, for your comments and questions. It's been a lively discussion. With that, we will close the workshop. Thank you all.
Thank you, John. Thank you, everyone.
Thank you.
Thank you.
John, you're making me think about more about this program more, clearly.
Good.
So your comment, appreciate it.
Good. All right. Bye, everybody.
Bye, everybody.
Bye.
Bye.